So we've been using Crystalvue technology here at Imperial for the last 4 or 5 years. The particular value of it is that it's contrast enhancing. So we take a 3D volume, we can manipulate it, adjust the contrast, adjust exactly the region of interest, and from that we can look at the baby's skeleton, baby's ribs, the baby's brain and the baby's palate, and most latterly we've been particularly interested in abnormally invasive placenta. The beauty about Crystalvue is that we see the edges of where soft tissue comes into contact with liquid or bone and is very, very pronounced, so we can see very well delineated anatomical structures. For instance, in the baby's brain we can see cysts or we can see hemorrhage, where normally on 2D or standard 3D ultrasound it's very difficult to see. For abnormally invasive placenta it allows us to see clearly, very well picked out, the bladder mucosa, the uterine serosa, and this will allow us to assess with what we think is a fair degree of accuracy the depth of invasion of the placenta, for instance. So what does Crystalvue give us that other modalities don't? Well, it allows us to see anatomy really clearly. It allows us to manipulate a volume because this is a post-processing technique, and we can pick out the part of the baby that we particularly want to see. Crystalvue and realistic view are not difficult to use. It all depends on having a good volume. So it's acquisition of a good volume, applying Crystalvue, realistic view, and then there is a degree of manipulation involved of the volume, but this takes seconds, not minutes. Now, it is true, as with most things, you get most out of it if you spend a bit of time with the technology. There isn't a textbook that tells you how to use this, but you can learn very intuitively from doing it yourself. And of course we have developed easy to use videos that show you which are the important controls to use to get the best out of the machine. So obtaining a 3D volume is really not difficult. It's exactly the same way you obtain a 3D volume in any other plane using any other machine. I find it is by far the best if you obtain in the highest quality possible, so extreme quality, which takes a little bit longer in acquisition, but unless the baby is moving, it's actually perfectly easy to do. And then the hard work starts really once you've acquired the volume and once you start manipulating the volume. I say hard work, it takes us a minute or two really to orientate the image and to get to where we want to in the anatomical plane in the placenta or the fetus. So here we have what I could call the crude volume. This is the volume going through the baby's this is the volume going through the placenta and the bladder. Now, what we need to do is to move into realistic view and Crystalvue, so that's a button that we press and adjusts to Crystalvue and realistic view, which is really important for this, to be able to see the contrast between the different tissue layers. And the next thing we need to do is, at the moment we've got a really thick slice of the placenta and the bladder, so what we're going to see is the ROI box moving. And this is a really important thing to do, and you can see as the ROI box becomes much slimmer and slimmer and slimmer, we have a thinner slice of the placenta and bladder, and you can see that tramline view appearing on the rendered image at the bottom right there, and that gives us the ability to see with confidence the bladder mucosa, and reasonable confidence also where the placenta ends, the placental retrolucency, and the myometrial border with the bladder. So you're seeing quite a few layers there. If we move from left to right, you can see the placenta, you can then see the placental retrolucency, you can then see the myometrium, and those two tramlines are the serosal side of the myometrium and then the bladder mucosa as well. If you're really clever, you can actually see inside the bladder as well and do almost a virtual cystoscopy, but that's probably not necessary for most of our cases unless you consider that there's a high risk of placenta percreta. So we're just going to do that again. We're going to adjust the ROI box so that we can see a much more clear tramline. and you can adjust in the X, Y and Z planes, and ideally you're completely orthogonal to that interface there, and you can see the most beautiful tram line there. Now it is quite important to go from right to left and up and down as well, because of course you might have an area of accretor that is relatively localized. So let's go from the right hand side to the left hand side, and we're moving through from one side to the other, and you can see the bladder on, I don't know if it's the right or the left side, but we're certainly moving right from one extent to the other. And once we've done that, we know we haven't missed out any bits of placenta or bladder. And as I say, you can be reasonably assured there that, as you've seen a perfect tramline, that both the myometrial and the vesicular bladder mucosa are intact. And that is very reassuring when you come to surgery, that this is very unlikely to be placenta accretor. So we've now acquired the volume. We've acquired the volume in extreme quality. So you can see here we have the bladder to the right again, and we have the placenta in the centre and to the left. Now it's really important, having orientated the volume as we have here, that we then use the ROI box, and I'm just going to show you how that works, because the ROI box will restrict the thickness of the slice. It's easier to do this if we also put realistic view and Crystalvue on. So we're just going to turn realistic view and Crystalvue on, and I want you to see the difference between having a really thick, if I can put it like this, a wide beam ROI box and a thinner one. So we're just orientating that volume. You can see the bottom right, the rendered image shows the bladder to the right and the placenta to the left. So we've got beautiful view there of the placenta, the clear zone, the myometrium, the bladder mucosa and the bladder. I think that's a great image. Now what I want to do is, let's go to ROI now and just go to the maximum ROI size. Maximum ROI, that's it. Okay, so now let's restrict it further. So the maximum ROI size gives us a thick slice, and we just need to reorientate slightly as we make the ROI smaller. So the ROI should sharpen up the image. You may have to reorientate slightly as you do this, because of course the ROI may take you slightly out of the perpendicular plane. But you can see here, again, in the center of that surface rendered image, you can see that beautifully clean bladder mucosa on the right and the myometrium there on the left, forming two lines, which is what we call the tram line. I think that we can also see, and I'm hoping we can just orientate slightly to see the placenta and the clear zone behind the placenta and between the placenta and the myometrium. So that's a good image. Now we can see that we can see where the placenta ends and the clear zone starts. So those are really the anatomical structures: placenta, the gap between the placenta and the myometrium, which is really clearly shown there, and then the bladder mucosa and the bladder. So once you have orientated your volume, you've got the ROI slice thickness correct, you're seeing the tram line, you can further enhance this image, and you can do that with the HDVI mode. HDVI enhances the Crystalvue image, and we're going to just take you through some of those settings now. It really applies a 3D filter, eliminates unwanted noise, and allows us to see the anatomy more clearly. And you can see, I think that's quite a clear image, and we've gone from a less clear image to a sharper image. So this is, I suppose you could say, it's a sort of 3D contrast and extraneous noise elimination button. It's one of those settings that you have to use yourself and decide for yourselves which setting is best, which filter type is best. We don't have a specific algorithm for which one we use. We try them all and decide, given the different circumstances, which is best. We do have a pre-saved preset, which is the fetal brain preset, which seems to work very well on the placenta as well. So let's just go through those different settings, because there was one a moment ago that wasn't very clear, deeper, that one, and then we got to one which was very sharp and showed the interfaces really well. Okay, so in this case we can see there the bladder mucosa. There was, as I said earlier, a question of whether this was placenta increta or percreta. We felt it was accreta stroke increta, and the MV flow and the Lumif flow allowed us to see that there wasn't vascularity, bridging vascularity through into the bladder mucosa, but there was a lot of vascularity very close to the myometrial edge. So that really supported us in our diagnosis of placenta accreta or increta. So we're using MV flow and Lumif flow here, and MV flow allows us to visualize very low velocity flow in very small vessels. This is an image where the B mode is on the left and the MV flow and Lumif flow image superimposed on the B mode is on the right. And we can see here how the MV flow, Lumif flow picks out very nicely that vascularity in the lower uterine segment between the placenta and the bladder mucosa, but critically does not show the vascularity across into the bladder mucosa. So often if you use standard colour Doppler, you just see a whole, what I call a fruit salad, which is lots and lots of different colours in random order distributed around the image. Here we can actually see individual vessels, and we can see the blood flow, and we can see that those tortuous bridging vessels are not present. So let's just look at this 2D image, and as I've already explained to you, what you want to see is the bladder to the right, and to the left you see the placenta and you see fetal parts and amniotic fluid. And this is really the perfect view that you acquire before pressing the 3D capture button. You need the capture box size large enough to capture the placenta, a bit of the amniotic cavity, and also the bladder, because that then gives you a 3D image that is a 3D volume that is large enough to process, and importantly you can then see from left to right on that 3D volume. Yeah, so this was a case that came to us as an emergency at 18 weeks, having had some intra-abdominal bleeding and a laparotomy at a local hospital. So as I say, this is an early image, this is an early volume at 18 weeks. 2 previous cesarean sections, bleeding at laparotomy, which we think was bleeding from a serosal vessel on a thin lower segment. Of course, technically the lower segment isn't formed at 18 weeks, but in practice, some of these women with thin scars, you can see a thin, what appears to be the lower segment. And here we have the placenta, which you can see very clearly, and if you contrast this with the previous Crystalvue case I showed you, you cannot see the clear space behind the placenta, the echolucent space between the placenta and the myometrium. It's just disappeared. So immediately that raises a serious concern. That's a red flag. And then if we try and look at the myometrium, the left hand of the tram lines, you can see it in certain parts, but in others it is obliterated. And you need to trust me here, we have orientated and we've used the ROI, and we just can't see a continuous tram line throughout here. In fact, on other images there was a slight concern about depth of invasion, and we had a lot of discussions between ourselves as to whether this was increta or percreta, but we came to the conclusion that this was placenta accreta stroke increta, which was subsequently confirmed at delivery at about 28 weeks after a large bleed. So I think this is a very nice case because it shows us those attributes that we saw previously on the normal case are not seen here. Loss of the retroplacental space, non-continuity of the left-hand tram line, telling us that there's myometrial invasion, but we can see that the bladder is intact, the bladder mucosa does appear to be intact, so we felt not percreta, and as I've said, that was confirmed histologically. The lady did need a hysterectomy because of major bleeding and because of placenta accreta increta.